Today's topic is antifibrotic therapy in cirrhosis. So, what is liver fibrosis? Liver fibrosis is ineffective wound healing process that occurs in response to repeated and chronic liver injury. If this injury is persistent and chronic, it leads to perpetuation of activated hepatic stellate cells, which gets converted to myofibroblasts. If the causative etiology is removed, it leads to apoptosis of myofibroblasts. So, this was the basic mechanism of liver fibrosis. Coming back to the antifibrotic treatment in liver disease, we have number one, treatment of underlying cause. You need to treat the underlying cause. For example, if a patient is having hepatitis B, you will give nucleotide or nucleoside analogs. In hepatitis C, direct antiviral agents. In autoimmune hepatitis, you can give steroids. For bile duct obstruction, we can do bile duct decompression and hemochromatosis, iron chelation. So we need to remove the underlying cause. For decreasing fibrosis, for reversing fibrosis, it is very important to remove the underlying etiology. Now, second is inhibition of inflammation. Various drugs have shown promising results like corticosteroids, caffeine, and colchicine. These are the drugs that can inhibit inflammation. Now, coming to immune modulation. Natural killer cells, they kill activated hepatic stellate cells. As a result, there is decrease in hepatic fibrosis. Serum amyloid P is a galectin 3 antagonist. When there is decrease in macrophage activation, it leads to decreased hepatic stellate cell activation. Now, number four is hepatoprotection. In hepatoprotection, we have hepatocyte growth factor. And this hepatocyte growth factor, it suppresses TGF beta mediated collagen type 1 transcription, which we know in cirrhosis the predominant collagen is type 1. And caspase inhibitor, it prevents apoptosis of hepatocytes because damaged hepatocytes or apoptosis hepatocytes is a pro-inflammatory signal. Number 5, FXR ligands. These FXR ligands, they decrease cellular activity of hepatic stellate cells, and they decrease hepatic stellate cell contractility. They also inhibit TIMP1 expression in hepatic stellate cells. Number 6, downregulation of hepatic stellate cell activation. We have a number of drugs in this group, like interferons. In interferons, we have interferon gamma. This interferon gamma decreases type 1 and type 4 collagen. Cannabinoids. We have two types of cannabinoid receptors. One is CB1 and CB2. CB2 is antifibrogenic, while as CB1 is fibrogenic. So, for decreasing liver fibrosis, we have CB2 agonists and CB1 antagonists. Antioxidants. Among antioxidants, we have vitamin E, N-acetylcysteine, quercetin. These are some antioxidants that can decrease hepatic fibrosis. Silymarin. Silymarin is derived from milk thistle, and it has been seen it has a promising antifibrotic activity. ACE inhibitors. Angiotensin II has been seen as a pro-inflammatory and pro-fibrogenic, while as its inhibition is anti-inflammatory and antifibrotic. TGF beta antagonists, like we have recombinant SMAD7 and curcumin. These are TGF beta antagonists. They are also anti-inflammatory and antifibrogenic. And endothelial receptor antagonists like bosentan has also a role in decreasing in downregulating TGF beta activity. Now, another is cytokine antagonism. In this group, we have Gleevec, and Gleevec is actually a tyrosine kinase antagonist, and it inhibits liver fibrosis. We have also selective inhibitor of Rho-mediated focal adhesions. We have monoclonal antibody to PDGF beta chain. Now we have another group that promote stellate cell apoptosis by disruption of integrin-mediated adhesions. Among them, we have TRAIL ligand, which causes hepatic stellate cell apoptosis, and gillotoxin. Number 9, we have another group, the agents causing matrix degradation. In this group, we have TIMP1 antibody and TGF beta antagonist. They both downregulate TIMP, which leads to decreased fibrosis. Another agent is LOX2 antagonist. Lysyl oxidase is important for cross-linking of collagen. So with antagonism, we decrease cross-linking and thus fibrosis.